When you disconnect your patient from the ventilator, you have to turn the ventilator off. While the patient is on the ventilator, there are certain things that you can change daily or weekly, like your ventilator circuit, or the bowel suction catheter, the H&E, okay? Those things are part of ventilator management, and sometimes there can be problems too, okay? So now, let's look at changing ventilator circuit. Okay, the reason you want to change the ventilator circuit every once in a while is to decrease nosocomial infection. Now, nosocomial infection is infection that the patient did not come to the hospital with. They got that infection while they are in the hospital. Okay? The ventilator circuit will get dirty, okay? And as you're treating your patient, giving them antibiotic, because the ventilator circuit is dirty, okay, you're blowing bacteria back into their lungs. Okay? So that will cause recurrent infection. So anytime you find out that it's dirty, you need to go ahead and change it. Otherwise, the infection will never go away. To decrease length of stay on the ventilator, and that is true. If the patient has infection, the length of stay on the ventilator increases, okay? But now if we can make sure that the ventilator circuit is clean, okay, then we'll be able to get them out of the ICU quicker, okay? Now, I think I've said this before, I think in this class, that most people think that the more patient you get, the hospitals get, the more money that they're making. Not necessarily. Because Medicare only pays about 62 cents to a dollar. 62 cents. And take a patient like a patient in the ICU. One day a patient is inside the ICU could cost up to $8,000 a day. Because you have the respiratory therapist taking care of the patient, you have nurses, you have social workers, you have the doctors coming in. So the ICU is actually supposed to be called expensive care unit. So if you get your patient in there and get them out quicker, that's good. The hospital makes money. But if they stay there forever, then they're losing money. All right? So we want to decrease length of stay by making sure that the patient doesn't have infection over and over. Okay? When should it be changed? The frequency of change depends on the hospital you work. Okay? Should not be changed on a regular basis. It's not something that, okay, let me go change this. No. Look, the more airtight the system is, like if you have it hooked up, everything hooked up, bacteria cannot get in. But if you keep on breaking the circuit, okay, every day you're opening up, trying to do something, the bacteria gets in and then into the patient's lungs. So you don't really have to change it unless you have to, okay? Circuit is contaminated or is malfunctioning, you can change it. Change ventilator circuit PRN. PRN. If you see something wrong with it, you change it. Otherwise, leave it alone. But the more you're opening up and doing stuff, the more bacteria is getting in. Here are the steps involved in changing the circuit. You're going to gather your equipment, get a new ventilator circuit, assemble the equipment using a safety technique. Make sure you have your gloves on. Wash your hands, put on your gloves. Observe the patient's vital signs. Okay, their O2 saturation, their heart rate, their blood pressure. Because once you're done, those vital signs would have to come back the way they were before you started. Hyperoxygenate the patient, disconnect the patient from the ventilator. Okay, so you're gonna detach the patient from the ventilator first, okay? Another therapist will be bagging the patient then. You hook up your bag, we're gonna do this in the lab next week, and then, you bag the patient, then that will give the other therapist enough time to patiently put in the new socket. Disconnect the old socket and connect the new socket to the ventilator, and then connect the patient to the ventilator again. Hyperoxygenate the patient, and then you take your post-vital signs. If the patient's O2 sat was 95 before you started, we'll better return to 95. Okay, if it's lower than that, something is wrong, okay? And then it is always a protocol to do a ventilator check anytime you change socket. Okay, every time you change your socket, you have to do a vent check to make sure that the numbers are still the same. If you transport your patient to another area in the hospital with the ventilator, and then you're back in the ICU now, in their room, you have to do a vent check. Anytime you move that patient from the ventilator and pick them back up, you do a vent check. That's protocol. Okay, remember that for your clinical simulations. And then you have to chart. You chart, the date that the doctor's socket is changed, the complications, how the patient tolerated that, whether they desaturated very rapidly or they didn't have any problems. You chart that so that the next time another therapist comes to do it, they'll be very careful knowing that, well, this is what the patient went through the last time we did it, so they'll be prepared for that. Any questions about that? Okay, so now let's say that I just got through changing my ventilator socket, and then my low pressure alarm keeps on going off. What does that tell me? Yeah, there's something that I don't really have there, so I have to troubleshoot for a leak. So that's the kind of question that you may get on the exam. Okay? How about the high pressure alarm or the low pressure alarm keeps on going off, and you walk into the patient's room, but you don't know what it is right away? What would you do immediately? What would be the safest thing to do for the patient?
See if you can pass the suction catheter?
Huh?
See if you can pass the suction catheter?
Yeah, what you're gonna do immediately, you disconnect your patient and you start bagging them. Well, because you can't stay there forever looking for what it is, So if you walk in there, you don't know what it is, remove your patient and start bagging them. Another therapist comes on and takes over, and then you can troubleshoot, okay? All right, here's the HME, heat moisture exchanger, okay? We call it the artificial nose because it does what the nose does. It humidifies the air that we breathe, it filters the air that we breathe, it warms up the air that we breathe. So the way that the HME works is that the air goes through it, through that spongy stuff inside it. That's called the hygroscopic material. Hygroscopic. That's that spongy looking stuff inside it. So the air goes through that and goes into the patient's lungs. And then when the patient exhales back, the spongy material will capture the warmth in the exhaled air. And then during the next inspiration, you will use that warmth to deliver the next breath. Okay, so if you don't have heated humidifier, you can use the HME. But as far as the test is concerned, HME is only for short-term use to provide mechanical ventilation, 1, 2, or 3 days, because it doesn't provide 100% humidity. It only provides 70% humidity. Okay, remember, when you intubate somebody, you're bypassing their upper airway. So we want to make sure that the oxygen and the air pick up enough humidity. So that's why we use the heated humidifier. When you heat up your gas, the gas picks up more humidity. Okay? So, but you can use HME. There is a question on the exam that says that a patient is being ventilated with HME. The patient's secretions are now becoming very thick and very difficult to suction out. What would the respiratory therapist recommend? Well, you know that the HME only provides 70% humidity. That's not enough. So what we're going to do is we're going to switch the patient to a heated humidifier so that we can begin to hydrate their secretions. Okay? All right. So this can cause problems. Sometimes secretions can build up inside that spongy material there. So since air has to go through it, it causes increased airway resistance. Okay? That will mess up your ventilation, that will mess up your oxygenation, that will cause your PIP to go up. That can cause patient ventilator asynchrony, for instance. Because remember, when the patient wants to trigger a breath, they have to suck in. Okay, so go beyond that obstruction inside the HME to turn the ventilator on. So it makes it harder. It increases work of breathing when that stuff is very, very wet. Okay? So anytime you look at it and you think that is dirty, is wet, the person needs to change it. Okay? You change it right away. All right. HME causes mechanical dead space to go up. Remember now, mechanical dead space is any amount of volume between the circuit and the patient. Okay, well the HME may be about this big. Most of them will hold like about 20 milliliters of volume. So it constitutes mechanical dead space. But that dead space doesn't really cause any problems. Because now remember now, here's the socket here. Okay, here's the patient over here. So we have the HME, and then we have the balanced suction catheter like that. Those two things. So the HME is 20 milliliter. The balance, depending on who makes it, will be about 80. That one length of corrugated tubing that comes with balance. You add these two here together, it's only 100. But what we said is that normal mechanical dead space is 150 or less. So although this constitutes mechanical dead space, it doesn't really cause your CO2 to rise as much. So what we're saying is that if you have any volume in the amount greater than 150, that can cause you to rebreathe a lot of CO2 that can change your arterial CO2. Okay, so it doesn't mean that this here would not cause it to rise, but it would not cause it to rise significantly. So that's why we say that when somebody has acidosis, you remove any kind of dead space that you got, even if it's one. Okay? Any questions about that? The aim of doing that, reduce infection. If you see that it's dirty, remove it. Okay? Reduce high PIP. If it is wet and dirty, can cause your PIP to go up. Reduce patient workup rate, yeah. Because it makes it very difficult for the patient to trigger the ventilator on. You have to go like that. Okay? Frequency of change as needed. Just look at it every morning when you go to manage your patient, take their HME. If it is salt, remove it. Okay? But if there is no frequency to it. You can't change it every 4 hours or every 2 hours. It doesn't work that way. It's just one story. Okay? Now, this is that question I just told you. Change to a heated humidifier device if secretions are becoming very thick. Because the HME can only provide 70% body humidity. But the heated humidifier can make it 100. Okay? It is not recommended for infants because it adds air space and the infant ET is uncuffed. Okay? So we don't use HME for infants. So the next thing that you can change is the bowel suction catheter. Bowel suction catheter. Okay? Closed suction system prevents cross-contamination, okay, and nosocomial infection. You know, it's got that plastic wrap over the catheter so that you can't actually touch it. But then it doesn't mean that you don't have to wear your gloves. You still have to wear your gloves. But the tendency for you to cause cross-contamination is minimal, okay, because of the plastic sleeve, okay? All right, and then here's a question there. And the exam, the patient is on the ventilator, okay, and is having open suction done on them. Okay, open suction is where you have to put on your gloves and do with the other type of suction catheter, right? You know which one I mean. So they go like, well, each time the respiratory therapist disconnects the patient from the ventilator to suction them, their O2 sat drops rapidly to 80 or 70. What would the respiratory therapist recommend? You would recommend bowel suction catheter because that way you don't have to. You can suction the patient while it's still attached, right? So that will stop you from disconnecting the patient from the ventilator and doing that open suction. Okay. Prevent frequent interaction in patient ventilation. There you go. Continuous suction applied when suctioning. If you're using the ballot, you like, hey, how are you doing?
Got some pens for you guys for your anniversary, peanut anniversary gift.
When you get your pen, if you don't like it, you give it
These
to
are
me.
really nice pens, just
Yeah.
FYI.
You put one in my office, right?
I did.
Thank you.
These are the ones we steal from each other from time to time. But enjoy them. Happy anniversary.
Thank you.
Dr. I appreciate it.
Okay. All right, so with the ballot, you suction once you fill in the catheter, you press it down, you hold it, and then you pull back. It goes like that. You don't do intermittent suction like that. When you're doing open suction, where you have to put on your gloves, sterile gloves and stuff, then you do intermittent. But if the patient is intubated or tracked, and you're using the bowel suction catheter, you put it in, you press it down and hold it down, you pull back. The reason for that is that if you do intermittent suction while they are intubated or tracked, that can decrease some of their tidal volume. Okay? That negative pressure will decrease some of their tidal volume. Okay? And plus, the whole thing is airtight. There's no other way for air to go into your lungs. All right, so remember that. It's also an exam, I've seen it before. Manufacturers recommend changing daily, but study shows that it can be changed once a week. Okay, once a week. So on the exam, you pick once a week. All right? This is where now you discontinued the ventilator. okay? When you discontinue the ventilator, you estimate your patient and staff, all the ventilator accessories, the balance suction catheter, the HME, the ventilator socket, you have to strip the ventilator inside the patient's room and put all of that inside the trash can in the patient room. I mean, you can drag it across the unit, right? You're causing cross-contamination. So strip the ventilator inside the patient's room, put everything there with the patient, and then drive the ventilator to the dirty equipment room, okay? Now, in some hospitals, the respiratory therapist is responsible for cleaning it up. At other hospitals, you may have somebody that does it. Okay, so you take it there, they clean it up, and get it ready to go for another patient. Some of the accessories may be sterilized or need sterilization, like the filter. We have to sterilize that. Okay, they are not disposable unless something is not wrong with it. So, if that's the case, you have to wrap it up and take it down. What do they call them? That was what they call that, the people that do the.
Biomed?
Huh?
You talking about biomed?
Yeah, biomed. No, is it biomed? I think they call them environmental services. But whatever it is, you take it down there and then they will sterilize it. Okay? Now we talked about ways to sterilize equipment. We talked about autoclave, okay, that's heat and pressure. Anything that heat or pressure can damage, you don't want to do autoclave, okay? Then we talked about ethylene oxide. That's gas. You can use gas and kill everybody, okay? You kill everybody, okay? Or you have glutaraldehyde. That one is mainly for the bronchoscope. That's liquid. Okay, anything that liquid cannot destroy, you soak it there for more than 2 hours. Okay? Bag, that's very important. You gotta pick that on your clinical simulation. If your patient is on the ventilator and you're doing a brain check, you have to pick it. By the way, anytime you walk into a patient's room that is on the ventilator, that is the very first thing that you look for. The very first thing that you look for. Once you say, hey, how are you doing? You go, well, where's my ammo bag? Because you know what? Once you start messing with that patient and somehow the ET tube comes off, well, I hate it if you have to run to the 7th floor to find an ammo bag. By the time you come back, you may not have a patient. So you look for your ammo bag before you start messing with your patient, so that if anything happens, you grab it there and start ventilating your patient. Can you imagine that? Well, think about it this way. A patient is paralyzed with a paralytic agent, they're like this. You also paralyze their diaphragm, they can't breathe spontaneously. The ventilator is just ventilating them, but then you go in there and the patient accidentally becomes extubated, but you don't have any ammo bag. If it takes you 10 minutes to run up to the 7th floor or to the department to find one, when you come back, it means that for 10 minutes that patient has not taken a breath. So it's very important, you gotta look for it. Okay, so now, when would you disconnect your patient from the ventilator? When is it that an emergency will arise and then you disconnect your patient from the ventilator? The first one is tension pneumothorax. The high pressure alarm is going off from breath to breath. That's the first thing that may tip you off to that. Well, something is wrong. Every breath. Okay, so you go in there, you begin your assessment. You listen to the patient's breath sounds. That's really the first thing you have to do. And then on one side, breath sounds are absent. And then on the other side, breath sounds are diminished. So on the side where the breath sounds are absent is where the pneumothorax is. That's tension pneumothorax. That's the only thing that can cause breath sounds to be absent. Or maybe you just don't have the GT tube inside your lungs. You put your hands on their chest, just as caution. The side where the pneumothorax is will be decreased excursion. It will not rise up as much during ventilation. The other side will rise up. You look at your patient's color. Patient will have cyanosis. Cyanosis, they'll be blue when they are having symptom pneumothorax because they are not oxygenating. You have a lot of air inside the pleural space that is compressing the lungs. So the lungs can expand. Before you can oxygenate, you have to expand your lungs, and then oxygen has to diffuse in. But now it's not opening up. So that's why they will turn blue. Trachea shift. Your trachea can shift, but now I want to warn you, sometimes it may take up to 24 hours before you see that. It's not like they have tension pneumothorax, all of a sudden they go like that. It may take hours before the trachea will shift, okay? And also it depends on the degree of the tension pneumothorax. Percussion notes, like that. You're gonna hear unilateral hyporesonance. Unilateral hyporesonant percussion notes on one side. Okay. Now, on the exam, if you're told that the patient has bilateral hyporesonance, that's not pneumothorax. That's CBEP. That's obstructive disease. Because emphysema, bronchitis, chronic asthma, each one of them happens inside both lungs. Okay? You can have emphysema on one lung and not have it on the other one. You can have asthma on one lung and not have it on the other one. But you can have pneumothorax on one side of the lung or not have it on the other one. So if you say unilateral hyporesonance, that's pneumothorax. If you say bilateral hyporesonance, that will be obstructive disease. Okay? O2 saturation will drop, blood pressure will bottom out. Blood pressure goes down. You know why? Because all of that air leaking inside the lungs is increasing intrathoracic pressure, therefore decreasing venous return. When you have more pressure inside your chest, your venous return decreases, which then decreases your blood pressure. So tension pneumothorax is continuous leak of air inside the pleural space. And the air goes under pressure very quickly, then compressing the lungs. Okay? All right, the next time that you want to disconnect your patient from the ventilator is when the patient has critical emergency code. It's something they call it code blue. Okay? Code blue has been called, and you're the first respiratory therapist to arrive at the scene. Well, if you want everybody to clap for you when they get there, just go ahead and disconnect your patient and start bagging them, at least if you don't know anything else to do. When they come, they'll say, oh man, you are very good. So disconnect them and start bagging them out like you know what you're doing. You may not know more than that, but that's something. Okay, so we're going to disconnect them. We're going to start bagging them with 100% oxygen. Where would we set our liter flow when you bag?
All the way at the top.
Is it flush? 15 liters per minute. 15 liters per minute. If you set it on flush, it causes increased airway resistance when you're bagging. So 15 liters per minute. If for any other thing for the test. Okay, but 15 liters per minute is where you set it when you bag. Okay, now another thing is that even if you're COPD, no matter who you are, and you have critical emergency, you get 100%. You know how we say like you can't give a COPD too much oxygen? Well, when they have cardiac arrest or respiratory arrest, they will get 100%. No matter who you are, you get 100%. Troubleshooting, okay? An alarm has gone off, and then you walk into your patient's room. Mr. Smith, are you okay? And the patient goes, and then instead of you disconnecting the patient immediately and start bagging them, you go, okay, wait a minute, let me see here. God, is that still plugged up over there? My God, you don't do that. That's not patient safety. If you go in there, if you don't know what it is, the safest thing you're gonna do for the patient is to disconnect them immediately. Hook up and back, turn your oxygen on, and start bagging them. Okay? All right. We have technical difficulty. Or sometimes they call it ventilator inoperable or not. Something is wrong with the ventilator. That's what that is. Okay? You're going to disconnect your patient. You're going to start bagging them with 100% oxygen. Okay? When another therapist comes in, you disconnect that ventilator from the wall and then move it out. Take it away, put some sign there, broken or whatever. Because any ventilator that has gone inoperable cannot be used on another patient unless they come out and fix it. Okay, usually respiratory therapists don't mess with any ventilator that has gone inoperable. The technician, the ventilator company will come out and open it up and see what's going on. Okay? Now, responding to alarm, okay? When the alarm goes off, once you go into the patient's room, you talk to your patient, Mr. Smith, are you okay? You have to do that. Because the reason that you're going in there is to treat your patient, not the ventilator. So you should not be looking at the ventilator first. You look at your patient first, okay? And then another thing is that don't silence the alarm if you don't know what is going on. Because once you silence the alarm, then you won't be able to tell why it went off. Okay, just ask your patient, are you okay? Okay, all right. Okay, what's going on? Yeah, I see it. You silence the alarm and then you fix the problem. Okay? Any questions about that? All right, so we're done with our lecture.